So our first lecture is going to talk about the elderly and the cognitive impairment that might be commonly seen in your older adult. Now, in 301, we talked about both the normals and the abnormals that you would see in your older adult, but in this particular lecture, we're just really going to focus on the cognitive impairment. Dementia will be a whole different lecture, so we're actually just going to focus on depression, delirium, and the comprehensive neurological assessment Glasgow scale in this particular lecture. So whenever you take care of any patient, it's really important that you get a baseline neurological assessment. That's why they started with that when you did your health assessment and in fundamentals as well, because you really need to follow and make sure that you have a baseline on your patient as far as their neurological assessment. And this is very comprehensive. So not only are you doing the level of consciousness and mentation, you're looking at everything. That's why they made you do all of those cranial nerves, which we aren't going to go over in this particular lecture, but you should be able to know if something does not look correct. And in most of your med-surg patients, majority of them, you won't have to do that full cranial nerve assessment, but you will as you go into higher levels of care, especially into critical care. But you should be able to know if somebody's alert, if they're orientated. You should be able to notice movement and sensation, reflexes, and all of those little things. Those are important. So when we look at the bedside neurological exam, all of you should be doing some sort of level of consciousness. We're going to talk about the Glasgow Coma Scale, which is GCS. Of course, the mentation and asking those particular questions. And of course, taking your little flashlight and look at those pupillary reactions. You've done all of that in your head-to-toe assessments. It's very important that you not only do your vital signs, but you do these other assessments as well, especially if the patient is not cognitively with you on all areas on there. And so the importance of determining this baseline is because if sometime during the shift they will deviate from that normal, you have a baseline assessment where you can say, this is not normal, this is not how I started the shift, and I need to continue and figure out what is going on with this patient. So there's what different levels of consciousness, as you are all aware of, and that's where the AAO times 4 times 3 times 2 comes in. But there's also what the patient looks like. So full consciousness obviously is the patient that you want to be looking at you. They're awake. They track you with their eyes. Lethargic is more of the patient's really drowsy. Sometimes you'll see some of your lethargic patients if they've had a narcotic or an opioid of some sort. Maybe they've come back from surgery. Maybe they've just woken up. You're coming in on the day shift and they've had a good night's of sleep. You know, some of you are like that when you're at home. When you first wake up in the morning, you're kind of like, oh, wait, where am I and what time is it? Okay. Obtunded is more where the patient is really difficult to arouse and you almost have to pinch them in order to wake them up. So they may even drift back off to sleep after you wake them up. So obtunded is really exactly how it sounds. You know, they're just not quite awake and they're not staying awake, and it really takes a bit to get them awake. Stuporous is where you really have to shake them, and sometimes they don't wake up, so you shake them again. They feel like they're going to sleep, so you shake them again. So the only response might be that you pinch them and they'll draw their arm away, or you'll rub their arm and then maybe I'll swat at you, but they don't open their eyes. They may not verbally acknowledge that you were there. So they only respond really to a painful stimulus. Comatose, of course, the patient doesn't really respond to anything. Now we really get really concerned when the patient is more comatose, because what has sent them into this comatose state? You know, is it medication? Is it the patient's deteriorating? Maybe an event has happened to the patient. So when a patient is comatose, that's when we really get concerned. Now, the GCS, which is the scale that we just looked at, is what we call the Glasgow Coma Scale. This was developed in a way to kind of take a look and see what is going on with your patient based on how well they open their eyes, how well they move their body, and how well they respond to you. So as you can see on here, everything is based on a scale. Everything, the higher the number, of course, the better. The highest score you can get, as you can see on here, is 15. So you can't get any higher than that. You will never get 0 on a Glasgow Coma Scale. 0 does not exist. However, the lower the number, the worse off the patient is. As you can see here, if it's less than 8, intubate, because your person has gone into a coma. So as you can see here, if you have a score of 3, you have a patient basically who's deceased. So usually you'll see most of your patients hopefully between the 12 and 15 scale on your general med surg floor. If they are getting below 12 or if they're getting below 10, what may be happening is you have a patient who's significantly deteriorating and they may need to go to a higher level of care. So it's really, really important that you do your baseline assessment, and that's the importance of doing the Glasgow Coma Scale. As you can see on here, you have eye opening, you have a verbal response, you have a motor response. So this is just a pictorial for those of you who do better with pictures than with just looking at words. So obviously if they turn and they look at you, that's a 4. If they acknowledge you, smile at you, whenever they do, that's the 5. And of course if they actually they don't even need to obey commands. If they're doing things spontaneously, then of course that's a 6. And of course, as you can see there, different things go down. So when we get into face-to-face class, we will look at some examples and how you would score them. There is a YouTube video link in here as well so that you can take a look at that. Now, of course, we know AAO times 4. So, of course, AA stands for alert, or alert, awake, and they're oriented times 4. 4, of course, means that they know what their name is, they know where they are, they know what time or year it is, and they know why they're here. And you should be asking your patients this if you have somebody who is older, because as you know, your elderly sometimes tend to forget a little bit. And so it's important that they know where they are, especially first thing in the morning. Sometimes people may forget where they are, but they know who they are and they know why they're there. So give them a minute or so. So don't just assume that they really are confused to all 4 of the statuses if there's been a circumstance that's there. So again, it's always evaluate, reevaluate. That is what we do in nursing. We assess and then we reassess to make sure that's really correct. Pupils. We all know about the pupils. That's why we all have the little pen light. Now we need to make sure you know what the PERLA stands for. If you don't, go back and remind yourself. So PERLA, of course, stands for pupil are equal. They're round. They're reactive to light. The A is accommodation, and that's where you take the pen and you kind of go in real fast, and you should see the eyes kind of come together. So that's what we look to see. The normal pupil size varies. It's anywhere from 2 to 4 millimeters, and there's a little side thing on your pen light that gives you kind of a gauge of what that should look like. But the most important thing is that you should see the pupil react. And it should start at a level, and when you shine the light on it, you should see it go smaller. Now, the other thing that should be is that you should see consensus, meaning that not only should the right side work, but the left side should work equally as well, even if you're not shining a light on it. So that's why you'll see people put their hand kind of in front of the nose and they'll shine the light in one eye, but they're looking at the opposite eye to see if it also reacts, and that's what we call consensus. Of course, the motor response only will happen if the patient is awake. If you have somebody who's asleep, don't lift up their hand and tell them to squeeze if they're sleeping. So the patient must be awake and they must be willing to cooperate. And they also must be able to understand directions. So make sure you are looking at a language that they can understand. So if not, then you may need an interpreter on all the units, especially in the medical center. They do have a language interpreter that you can utilize on there, and you can look at it through that, or if there's a family member that can help you. Of course, we know the motor response. We know about squeezing the fingers. We'll talk about it and do an actual one when we're doing face-to-face. But when they squeeze your fingers, cross your fingers so that way they don't break your fingers. And then we talked about pushing and pressuring against the arm. And again, we will demonstrate that when we are in our face-to-face class, because you will do it against each other. Sensation, of course, is exactly that. What can you feel? Of course, we have kind of stayed away from the pins, and usually we use like the blunt end of the Q-tip, not the fuzzy end. Well, you can use the fuzzy end too, but the stick part usually we'll put on there if we want to look at pressure. Now remember, sensation must be equal. So if you do it to one side and then do it to the other side, the sensation must be equal. This also means that you should be putting the pressure equally. So don't be poking people harder on one side than on the other. So again, this is a cooperation thing. The patient must say, yes, it's okay for you to hold my toes or whatever. And so this is again where you can actually hold a person's toe and say, okay, which toe am I holding? And hopefully they'll be able to tell you which toe. Now for adult cognition, that's just really the process. When you look at the word cognition, really by dictionary terms, it's just a process of acquiring and storing your information. And remember, a lot of it is based on experience. And who has all your experiences but all your elderly? So when you're looking at cognitive function, you're looking at what is their train of thought, what kind of memory do they have, are they able to make judgment calls? Are they able to pay attention to you? Are they able to perceive what it is you're trying to educate them on? Are they able to speak language? And then, of course, are they able to put all of those things together in their conversation with you? Now, we always look at research on there, and we find that, again, depending on your older adult, how much education have they have? What's the environment? How nourished are they? So you want them to be at their optimal level. So there are aging changes in the central nervous system, and while they're not uh, too obvious in some cases, we do need to assess for them because sometimes they are very obvious, and then that will get us into uh, our dementia, which will again be in the other lecture. So we talk about neuroplasticity. Neuroplasticity is basically neuronal connections in the brain. So when you have positive neuroplasticity, this means that you are making those neuronal connections in the brain. So it's kind of that use it or lose it kind of theory. So you need to stimulate the brain to increase this cognitive reserve. And the only way you do that is to engage the cognitive mind. So one of the ways that you can do this, for example, is my parents were very into doing puzzles. My mother especially was into word search, and my dad loves Sudoku and anything with numbers. So doing puzzles is a way to really increase neuroplasticity. Engaging in conversation, actually even playing games on your computer, when you're having to do mind games and you have to do active thinking, that's increasing those neuronal connections and firing, and that's positive neuroplasticity. That's why we want people to be up and awake and engage with you and talk with you. We don't really want people to be sleeping all the time because, yes, people do need to rest, but when people rest, they're also not increasing their neuronal connections on here. So that's why it's really important that we look at engaging our people and talking with them and getting them up and not just letting them watch TV, but actually having them do something more active. And now cognitive reserve is actually based on um, how you've grown up. So it's all going to vary among people because there's genetics, there's health, there's education. What did you do for a living? The meaningful social interactions that they have. That's why those are the kinds of things that we ask when we have people coming on admission. Who is your support group? What do you do? And you see people sometimes have books at their table and puzzles at their tables, and they'll have their tablets in there because they do something to keep themselves active. Older adults are thought to use both hemispheres more equally than younger adults. So what happens is with experience, you're going to see some of your older adults have more ability to problem solve. They have better concept formation on here. So when you do education on them, you don't have to really re-explain many things because they've had the experience and they can put them together and actually understand what you're trying to bring across. So your older adults will see that much quicker than your younger adults. They also have greater density of those synapses. So that's really helpful so that your older adult, depending on what kind of experience that they have, are able to really understand your education and really join in helping themselves to get better. Now remember that in our memory we have immediate recall, we have short-term recall, and then we have remote or long-term recall. And when we start looking at some of our mentation issues with the adult, it's going to probably affect one of these three components on here. For example, sometimes after a person's had a stroke, they can do immediate recall and some short-term recall, but the remote or long-term is forgotten. And then when we get into dementia, the same problem. Some of them will lose all three of these and they won't have any immediate recall or short-term recall or remote or long-term recall. It's just going to depend on what the disease process is. Now remember, as you get older, sometimes it's harder to recall new information. And so therefore, if you've got an older adult and you're having to do some new education with them while they've had life experiences, because this is brand new, they may need some time to really get the hang, so to speak, of what's going on. So this is where um, our abundance of the social media sometimes is really helpful, and the online teaching is really helpful, and the videos are really helpful. And this is where even things like TikTok or YouTube become really helpful because they see It's like watching TV. They see it again and again, and that helps them to recall and restore and keep that information on reserve in their brain. It's because as a person gets older, it will decline this recall of new information. So processing, reaction time, the capacity for tasking, and majority of function as in the older adult actually will remain intact and sufficient. It's really when you add new things and add new layers that you might see more of a struggle. So remember, in cognitive impairment, we're not talking about one thing, okay? We're just not saying, oh, they're forgetful. There's multiple interacting processes here. So an accurate diagnosis is going to depend on finding what are those abnormalities in the mental status and the cognitive function. So there's an acute stage that can actually happen because maybe they've had an acute illness, maybe they've had surgery, maybe they've had a new drug that has come into play on here. So all of those affect the chemistry, not only in the body, but it can affect the chemistry of the brain, which will affect some of your cognitive function. So you've learned this in psych as well, that medications can alter chemistry in the brain, which is why some people will feel better depending on the drugs that they take. And also some people are at higher risk for doing harm to themselves. And that's why they talk about those side effects with your medications because of that change in the chemistry. It's the same thing in the cognitive impairment. When you have acute orders, acute illnesses that can affect how the body functions, you could have changes in the cognitive impairment as well. Now, the thing is that if you have a more chronic or you have a chronic illness, we might see a more slowly progression impairment of the cognitive function to the point where you might have somebody, when we talk about dementia, you will see something more of this problem because of the fact it's more of a chronic illness, not an acute illness. Remember, acute illness has an ending point. It is usually short term, okay? Um, Impaired cognitive function is also associated with your affective disorders and psychoses, which you learned when you were in uh, mental health class. So remember, being old, okay, just the fact that you're old does not cause impairment of cognitive function. That renders an individual dysfunctional. And a lot of you know that because a lot of you have grandparents that are active and that are fully functioning, as we call it, that are totally alert and they're oriented. And some of you have grandparents who are not in this capacity. But just the fact that they are old does not mean that you are now going to become cognitively declined. Okay? So just because you're old doesn't mean you're now cognitively dysfunctional. Depression. Now, older adults actually do not get depressed. Majority of the adults are really happy with their lives. And a lot of them are happy to have their lives extended through their children and their grandchildren. And they're out and about. They're functioning independently. They live in their own home. But they have to understand too that there are late life stressors. And those can change not only a person's health, but also belief in their own beliefs in how they interact with society and how they interact with health professionals. And so this is where we're going to see maybe some symptomology of depression. Because while it's true that majority of your older adults are very happy with their lives, remember there are some late life stressors that could happen. There might have been one of the spouses gets ill, and that's going to change the belief and the outlook of the other spouse, especially if it's a significant illness. And we'll talk about that when we get into dementia and caregivers as well. Okay, so you need to understand that, yes, depression is not a normal part of aging, but it still can happen. So what are we going to look for? That's the problem. In depression in older adults, sometimes not only does it get underdiagnosed, it actually gets undertreated because they think, oh, well, you're old, therefore you must be depressed. Because, like we said, depression is not a normal part of aging. But yet we assume that the older person will get depressed because they're getting towards the end of their life. And that's a terrible, terrible assumptions we should make as caregivers. Okay, and that's why it gets underdiagnosed and undertreated because we're not looking for those signs and symptoms. So the prevalence rates of the depression in older adults is probably underestimated at this point in time based on the diagnoses alone. Okay, and remember, a lot of older people, even though they're exhibiting those signs and symptoms of depression, there's a lot of stigma associated with depression. And so even in the young adults, let alone older adults, there is that stigma that is, oh, if you're depressed, you're not happy with your life, whatever, blah, blah. Okay? So health professionals, us, meaning us, are often expect the older person to be depressed because they're sick, but that may not be the case. So we don't take the appropriate action to really assess and treat true depression, because depression could look like something else. It could look like dementia, it might look like delirium, and so then it gets untreated. And on top of that, remember, there's racial, ethnic, and cultural considerations. As we all know, we all come from different backgrounds. We all look at health differently. We all look at how the older person should look. Okay, so, and there's a lot of people who hold a lot of their emotions in. So we classify them based on those particular emotions. And so that's why, as nurses, we really need to be more open-minded and really look at the whole assessment before you make a judgment call and say, oh, the person's just withdrawn because they're just depressed. When you need to look at, okay, well, what is the racial consideration? Is there a racial consideration to even consider? Is there an ethnic thing? Is this, what is their role in the family? Those kinds of things. Older women suffer depression at twice the rate of older men. Um, and you can see on here some of Hispanics 50 and older have more depression than other groups. So again, you need to look at all factors before you classify somebody as being depressed. What are the consequences? The problem is that consequences of older adults who are depressed can actually lead to serious medical conditions. Because what usually ends up happening is that you can see here that it's second to heart disease and causing disability and harm and health and quality of life. And unfortunately, some of the negative consequences, for example, is they will ignore their own health, so they'll get very malnourished. They if they have a comorbidity, it could exacerbate the comorbidity and actually make it worse. Um, they could have a decreased quality of life, and then it also puts them at risk of ending their own life. The other thing, too, is that they get a little bit more, oh, what's the word I want to use here, where they get well, they start abusing the health services on there because they become a little bit of a hypochondriac. So you'll see them visiting the EDs quite frequently for pains that really don't exist physiologically when you x-ray them, when you ask them questions. It's a chronic pain. They can't point to where the chronic pain is. They can't tell you where it is and how long it's lasted. So they tend to end up using a lot of the health services and with their cognitive impairment because of this depression. So that's why when you see somebody who what we call lovingly in our profession a frequent flyer, start looking beyond the frequent flyer and look at the underlying condition and say, what is really going on with this patient, and could this be the beginning of a cognitive impairment like a depression? So people report, or the older adult report, more somatic complaints like insomnia, loss of appetite, the weight loss, chronic pain. Oh, here's the hypochondriac on here. So we do have a geriatric depression scale. You may have heard of it when you were in psych. So they may have talked about it then. So if you feel like you might have a person who might be depressed, you can use this scale on here. Remember that a lot of conversations that you have with your patient is developing trust and respect mutually between the two of you. So it's really important that you keep that respect with your patient. If you really think that they are suicidal, ask them about it. Don't be afraid and not ask them. You need to ask the hard questions like, are you really thinking about killing yourself? You just made a statement. Are you really thinking of harming yourself? Have you had this thought often? Have you decided how you are going to end your life? Or I wouldn't say decided, but I would even ask, do you actually have a plan to hurt yourself? Because you need to, this is not the time to kind of be afraid to ask the hard questions. You need to ask the hard questions because you need to know if this person really is going to hurt themselves, because we can then step in and do something for them. Now, the goal of the treatment of depression is to decrease the symptoms and then really try to figure out how can we improve function and the quality of life? How can we reduce the relapse of them feeling bad about themselves? And how can we reduce the mortality as well as prevent them from having to keep revisiting the ED because they've got chronic pain that doesn't really exist? Remember, your brain is a very strong tool and actually can make you physiologically hurt. There's non-pharmacological aspects of how we can intervene. There's also pharmacological aspects that we could do for intervening. Now, and there's also other treatments. As you know, there is such a thing as ECT or electroconvulsive therapy. We can also do, or actually they call it repetitive transcranial, basically electroconvulsive therapies where they electrically shock the brain in order to reset the neural connections on there. So hopefully what it does is it gets you out of that depressive state. And then of course there is therapy, family and professional support. And remember, to see a therapist is not a bad thing. I know therapists can get a bad rap on here, but people really need help. And we do have a, by the way, just so you know, on this campus, if you feel like you really are stressed with your life, if you feel like you're overwhelmed, we do have student um, uh, EAP here, a student personnel, where you can go and be seen and you could talk to a therapist. You can have 9 free visits. Nobody has to know that you're there. So if you feel like you're being overwhelmed in your life, and let's face it, school is really overwhelming, don't be afraid to take advantages of the student services that are here and available to you and are totally, like I said, respectful, and nobody has to know. Okay, but we do know that school is stressful. Suicide. Unfortunately, your highest risk for suicide are your white males who are 85 years or older. Thankfully, women do not have a high suicide rate. However, that doesn't mean that they do not commit suicide. And remember, you can't always see emotional pain. And when you get to that point where the emotional pain is just so significant and so vast, sometimes people see no other end but to end their own life. And so that it's really, really important that you assess and you really look at the person who is at risk. And again, don't be afraid to ask the hard questions. Do you feel like you are in a state where you feel like you need to harm yourself? Have you made plans to harm yourself? Those are the kinds of questions you have to ask. And to ask it of an older adult, you feel like, because you're asking your grandmother, your grandfather, but you need to be respectful in the way that you approach them. That's why it's so important that you establish your rapport with your patient as soon as you go in and introduce yourself to them. Okay, but look for those who are at risk. What can you do for that? As you can see on here, they're actually, look, preventing suicide in senior living communities. So they know that this can happen in your older adults. So you can have a suicide protocol in place. Obviously, if you feel like the person is going to harm himself, please don't leave them alone. People who are at high risk to kill themselves are hospitalized. Usually, this is for those of you who are SNAP students. This is why you have that sitter patient that's right there. Um, if they're at moderate risk, of course, they can be treated as outpatient. Of course, at low risk, it doesn't mean, oh, you're at low risk, so you're not going to hurt yourself. They should still follow up with a professional and find out how we can help them look at their lives and help their coping mechanisms a little bit better. So anybody who you think is at risk for suicide, please refer them, defer them, let your primary provider know. If you're in the hospital setting, let your nurse know that you're concerned because the patient has made statements. And then, have your nurse go in with you and also help evaluate what's going on with the patient, because they should never be left alone. Delirium. Delirium, first of all, I want you to take a look right below delirium. Acute confusional state. Okay, so delirium is an acute confusional state. That means it's very short term. Okay, the facts we know is that it's a common syndrome in older hospitalized adults, because when they are not in their regular home, unfortunately, as more time passes, it can cause, and especially because we go in there every 2 hours or every 4 hours to take their vital signs, it can get where they get mixed up in their days and their nights. So unfortunately, it's really important that you recognize when there is the beginnings of delirium in a patient. Early recognition is really important to minimize this impact. And you as the nurse are actually part of that role in discovering what is delirium. Okay. So, unfortunately, delirium can be mistaken for dementia. Your book and your ebook is also very good. If you want to go look at the table on there, you can look at some of the more significant signs and symptoms on there. So that's really, really important to look at. Unfortunately, if you don't catch on to delirium, it can cause irreversible brain damage if it's allowed to continue. That's why it's so important that you catch delirium, because majority of the time it is quite, once you recognize it is reversible. The definition of delirium basically is disturbance of consciousness with impaired attention and disorganized thinking. It develops really rapidly in the presence of an underlying physiological or medical condition. That's why you need to look at it right away, because if we can correct the physiologic condition or the medical condition, that usually will kind of bring them back, so to speak, and help with keeping them focused on the here and now and not kind of getting forgetful. What do you see with signs and symptoms of people who have delirium? Now, with delirium, a majority of the obvious one is that they do not know where they are. Okay, so you'll see on here there's delirium in the ED. So you have this acute onset and it fluctuates. So we have a hyperactive delirium and we have what we call the hypoactive. Majority of your patients are kind of mixed. But hypoactive is what we usually miss in the nurses. You can see on here, hypoactive is usually they're usually withdrawn. They might be really sleepy. Um, they might have they might have occasional forgetfulness. They'll ask you what time it is, that kind of thing. Notice on here the hyperactive one is the one that's more restless and aggressive. These are the people trying to get up out of the bed. These are people with hallucinations and telling you that there's somebody at the door and there's nobody there, or they're pointing to um, ants or something on the wall and there's nothing there. So every once in a while you might have delusional thinking that can happen on there, and they have misperceptions of the stimuli. So you're coming in and you're going to take the blood pressure and they're like, what are you doing to me, leave me alone, and they're pulling their arm away. So that's important. And then sometimes delirium is very subtle. um, it might be that, oh, hi, I'm your nurse today, and they're having trouble focusing on you or maintaining their focus or sustaining their focus, or they shift their attention away. They look like they're maybe a little ADD when they're looking up at something else, and they get very easily distracted. Now, a lot of times we see in our uh, hospital setting, where we see a lot of delirium a lot are in our surgical units. Anesthesia does a huge contributor to delirium. So you can even see here during hospitalization, 11 to 42% of older adults develop delirium after surgery. Now, notice specifically orthopedic surgery, hip surgery. And that's probably because of the length of surgery. Hip surgery takes about 4 or 5 hours. So, having been under anesthesia that long under the presence of drugs, you can see why they have the highest risk of developing delirium. Notice on here, there's a table on here from that says on here incidents during hospital admission after hip surgery, after any surgery, and during hospitalization that usually lasts longer than, usually it's a long acting, so a lot of your internal med patients who've been there for more than a couple of weeks usually, because again, you have lights on, lights off. We're in there all the time, every 2 to 4 hours. We don't go to sleep, but they don't either. So that's why you'll notice that nowadays the ways we intervene with some of this is you'll see some of the doors have signs that say don't wake them up between 2200 and 06, because they're trying to decrease this incidence of delirium. So you'll notice another place of a highest incidence is in intensive care units, because in the intensive care, they never turn the lights off there either. And a lot of your patients are intubated, and so it's very, very easy to lose track of time. The great thing about delirium is that it usually happens in setting and hospital setting. We rarely see it out in the community. If you see delirium out in the community, it's probably leaning towards more of an early dementia versus an actual delirium. Because remember, delirium is an acute confusional state. We really don't understand why people get delirium. We think a lot of it, of course, has to do, of course, with the chemical balance that's happening in the brain. So cholinergic deficiency or maybe dopamine excess. And then there's a cytokine activity. So you'll see here in this little circle of delirium on there, it's multiple factors um, contributing and not just one main thing. But a majority of it is the circadian rhythm gets thrown off, and then, of course, the chemical imbalances. Now, of course, there's multiple causes on here. Look at, there's predisposing factors, underlying cognitive impairment already. So maybe they're already a little bit forgetful. Maybe they are depressed. Maybe they have had an acute illness and it's gotten worse. Maybe they've had medications. Maybe they've had procedures. Again, sometimes, they may have been misconstrued on their actions, and so they'll restrain them. Sleep deprivation, maybe they have a full bladder and the because or they have a catheter and the bladder or the Foley tubing is kinked, so they feel full and they're trying to get up to use the bathroom, and what it is the catheter has been kinked off, and so it's been building up in the bladder, and you just undo the kink and then the urine releases. Maybe it's pain and medications related to helping with the pain. And then, of course, all sorts of environmental factors. And remember, these people are not in their own homes. So that environment in the hospital setting really throws them all off. Unfortunately, the terrifying experience for the individual can have significance in the hospital setting. It can actually increase the length of stay. It can actually cause hospital readmissions because the delirium doesn't quite resolve itself before they go home. They may need increased services after discharge, meaning instead of going home, maybe they need to go to a skilled nursing facility, a long-term acute care facility, which we call an LTAC. Sometimes if they don't get out of their delirium, it can actually increase morbidity, mortality, and we talked about having to go to a long-term acute care. Now, the interesting thing with delirium is because it's a chemical-based problem majority of the time, it really is independent of age, a coexisting illness, or an illness severity. So a lot of times when we're looking at delirium, especially in your older adult on here, it doesn't matter if they're 60 or they're 80. Somebody who's 60 might get delirious after surgery, the other one may not. So again, it's independent of age and a comorbidity at this point in time. It's really about what's going on in the body. So again, here is your predisposing factors, your precipitating factors of delirium, and then the poor health-related outcomes that we talked about earlier. This is just another depiction. So that's why you want to recognize so that we can treat, and then we can minimize the outcomes that might be more detrimental for the patient because we didn't recognize the delirium early. Again, there is another assessment tool we can utilize, and it's called the CAM, which is the Fusion Assessment Method. I have an example of a CAM tool on here, and you're welcome to print out this particular slide so you can just look at the questions on here. But really what it looks like at is um, it's the most widely used tool that we have for recognizing the features of delirium. And remember, we want to recognize it as soon as possible so that way we can treat it and and correct it, because especially if it's medication based, we can correct that very easily, and then the person can get out of their delirium status. Okay, so you want to use the standardized screening tool. So we use CAM, and you probably heard of the CAM tool as well, and we use it for your older adults, usually when we're trying to assess whether this person is having the features of delirium, or is this something much more of depression versus depression, which is the geriatric depression scale. So don't use the CAM for depression. We're using it to see if the person is delirious or having delirium or features of delirium. If it's depression, we use a geriatric depression scale, and then we have another scale that we're going to use for our dementia patients. So delirium unfortunately can occur concurrently with dementia or depression, and that's what makes it really, really difficult when we are looking at our readmissions. So it's really important that you include the family, because the family will recognize whether this person is delirious or not. It's the family who'll tell you, hey, this is not my mother. My mother is usually way more independent and is able to recognize things much more clearly. My mother is more confused. And so please believe the family when they tell you that the family member who is your patient is not at their baseline. That's why it's really, really important that you do that baseline cognition and you do that baseline neuro check right at the very beginning. So when you see when your family notices the changes, you also notice the change as well. Now, what do we want to do? We want to promote, this is the communication part here is again, it's very important. You want to promote that therapeutic environment. You want to prevent worsening of the condition. Sometimes people will get delirium because of oxygenation. So if that's the case, make sure that you have adequate oxygenation. Make sure that you're able to get them to the bathroom. If they have had surgery, get them up and walk them. You want early physical therapy, occupational therapy, or just even regular ambulation if they are not impaired in any way. So these are some of the things that we can do to prevent delirium from happening. Delirium intervention, you can see here we have non-pharmacological. So again, this is a person-centered approach. You'll notice here there's several strategies that have been discovered on how to treat delirium and using it without using medication. Um, Pharmacological treatment it's a multi-component. Well, it's usually I don't even drugs that a lot of times we're taking out drugs because it's usually drugs that cause the delirium. But again, pharmacological treatment should be approached doing other things besides just giving drugs. So, and be careful, well, not be careful, but just assess when you're communicating with a person who's experiencing delirium. Always keep reminding them, keep reorienting them, keep reassuring them that they're safe and that they're in a hospital setting and somebody is watching them. I think that's the one thing that the best thing that you can do as nurses is keep reassuring your patient that they are safe and that you are there to help care for them. If you have questions, we'll be doing face to face. Thank you for listening to this recording, and I will see you in class. Thank you.